What if I told you that the secret to unlocking better spinal health lies in a concept we often overlook, sagittal balance? Think of your spine not just as a series of bones and discs, but as a suspension bridge of your body, strong, flexible, and perfectly balanced. But what happens when that balance is disrupted? Today I want to share how understanding this hidden balance can influence how we approach spinal care. Imagine a straight line running down through your ear, past your shoulders, and right behind your hips. This is your body's natural balance point, a line that keeps you upright with minimal effort. But when this line shifts, your body starts to compensate, and that's where problems begin. To truly understand the spine's balance, we need to look at the entire structure, not just one part. We often focus on just one piece of the puzzle, a specific vertebrae or curve, a disc, a facet joint, a ligament, without realizing that the spine functions as a whole. It's like judging a book by a single page. We miss the full story. MRI is wonderful for looking at tissue. Regional x-rays might show a localized problem like arthritis, a fracture, forward head posture, or give us clues about disc degeneration or ligament damage, but they don't tell the whole story. Let me share an example that illustrates this point by going through the journey of a young patient who came to me after a car accident. On her first x-ray, we saw something concerning: forward head posture, a small kyphosis in the lower cervical region, and a lordosis in the upper cervical region. But when we zoomed out and looked at her full spine, the story got even more complex. Despite the lower cervical kyphosis, her cervical spine was in balance. Her C7 plumb line, which is the red line running down through C7, was positioned significantly posterior to the sacral base, as it should ideally fall near the posterior corner of the sacrum. Her body had cleverly compensated to maintain overall balance, even as her neck struggled. This is the power of seeing the bigger picture, understanding not just where the spine is out of balance, but how the entire system adapts. After a course of care, her alignment improved significantly. Not only did her pelvic tilt adjust closer to ideal, but her cervical curve also improved, reducing her forward head posture. Now look at her post-treatment x-ray. You can see how her spine has realigned with a more balanced posture and significant relief of her symptoms. This adjustment has been crucial in reducing the exaggerated arch in her lower back and restoring the cervical curve. To see the full extent of the problem, we also used motion x-rays, which revealed abnormal motion at C5. You can see C5 sliding excessively forward and backward over C6 as she bends her head forward and backward, further highlighting the significance of this segment's instability. This insight is crucial because it shows how the body's compensations, while maintaining balance, can also be the source of significant dysfunction. Without the full spine view and the motion x-rays, we might miss how the body is compensating to maintain overall balance. Now think of your spine as a suspension bridge. In each lordotic or kyphotic curve of your neck, mid-back, and lower back, acting like the cables that hold the bridge together. If one cable snaps, the whole structure starts to fail. This same goes for your spine. A slight change in one curve can lead to a chain reaction throughout your body. For instance, the apex, or middle of the cervical curve, is around C5, which is where we see the most stress, similar to the central cable of a suspension bridge bearing the heaviest load. If this curve is disrupted, such as by damage to ligaments in the area, leading to a loss of cervical lordosis, the entire bridge of the cervical spine is compromised. The upper thoracic spine might pull backward and stiffen in an attempt to compensate and support, which in turn affects the lower cervical spine, often leading to a forward kink. Understanding these biomechanical principles helps us to predict where the spine is most likely to break down under stress. By applying this knowledge, we can better diagnose and treat spinal issues before they lead to significant dysfunction. But to do this effectively, we need to look beyond static images and understand the spine's movement and its dynamic balance. To further understand how the spine compensates, we need to discuss three critical measurements: pelvic incidence, pelvic tilt, and sacral slope. Pelvic incidence is a fixed anatomical angle unique to each individual, developed during growth, and influences the alignment and curvature of the entire spine. During growth and development of the pelvis, the width of the pelvis from front to back determines where the sacrum sits in relation to the hips. In a wider pelvis from front to back, the sacrum is more likely to sit more posteriorly, and in an effort to maintain balance around the gravity line, the sacrum will tilt forward. Pelvic tilt refers to how the pelvis is positioned in the sagittal plane, reflecting how it compensates for spinal imbalances by rotating around the hip axis. Sacral slope directly influences lumbar lordosis. A higher sacral slope typically correlates with a more pronounced lumbar curve. What's exciting is that although the human spine is extremely complex and no two spines are alike, the fact that the pelvic incidence angle for each of us does not change gives us a constant value that we can then use to make sense of and calculate ideal positions and angles for each of our patient spines. In any mathematical equation, you have to have a constant, and pelvic incidence gives us that constant. Let's return to our young patient with the whiplash injury. Her pelvic incidence, seen in red, is 56 degrees, which is slightly above average. Initially, her pelvic tilt, seen in yellow, was 6 degrees, much lower than what would be ideal for her pelvic incidence. Ideally, her pelvic tilt should be around 13.24 degrees as calculated. After a course of care, her pelvic tilt improved to 14 degrees, much closer to her ideal. Along with this, her sacral slope, seen in green, which adjusted from 50 degrees to 42 degrees. This helped normalize her lumbar lordosis and reduce the exaggerated arch in her lower spine, in her lower back. Now let's look at the rest of her post-treatment x-rays. Notice how her spine has realigned with a more balanced posture, an improved cervical curve, and reduced forward head carriage. This improvement was crucial in restoring her overall spinal alignment and relieving her symptoms. Now consider an elderly patient with a high pelvic incidence of 65 degrees. This higher angle allows her pelvis to tilt backward more effectively, helping her to maintain balance despite significant spinal issues. She has undergone 2 lumbar fusion surgeries, which have provided essential stability and addressed the local pathology in those areas. However, because the earlier surgery, not performed by any surgeons in this conference, did not fully restore the lumbar lordosis, her spine's ability to compensate for forward head posture has been significantly reduced. While the surgeries have been beneficial in stabilizing her spine and relieving pain, they highlight a critical point: the importance of incorporating a comprehensive understanding of each patient's spinal biomechanics into surgical planning. Specifically, patient-specific lumbar lordosis based on their pelvic incidence measurements, which can guide the restoration of proper alignment, ensuring that the spine is positioned in a way that supports overall balance and is more likely to have a positive outcome. Although the patient's spine remains imbalanced due to the complex nature of her condition, she has shown significant improvement in her cervical position, which, while modest, has greatly enhanced her daily function. Here are the post-treatment x-rays. You can see the improvement in her neck alignment. This progress underscores the value of using precise biomechanical insights to inform and optimize surgical outcomes, tailored to the individual needs of each patient. While the full spine x-ray gives us a static picture, motion x-ray allows us to see the spine in action, how it moves or fails to move properly. It's interesting to see how this patient moves and compensates with 2 artificial discs and a fusion. Motion x-ray is especially important in cases of trauma, like with our young whiplash patient. Using motion x-rays, we can observe how our cervical spine behaves under movement. What we see is not just a lack of proper curvature, but also abnormal motion at specific segments, particularly at C5 in this case, indicating ligament damage. This insight is crucial for targeted treatments, whether we need to restore motion in hypomobile areas or stabilize hypermobile segments. Seeing the spine in motion allows us to diagnose issues that would otherwise remain hidden. It's like watching a bridge flex under load. You see where the weaknesses are, where it might fail, and where reinforcement is needed. In the end, the key to spinal health isn't just about fixing a single segment. It's about understanding how the entire system works together. Let's start seeing our patients not just as cases to solve, but as complex, dynamic systems. By embracing a full body view, we can not only treat spinal issues more effectively, but also prevent them from happening in the first place. Thank you.